she has made from some authoritative sources. I will say I can't give you her same insights as a psychiatrist, but I will tell you that in primary care, we see a lot of common mental health concerns and need to work with them. And all of us here are now working actively with patients who have a mental health co-diagnosis, whether we're recognizing that as part of our scope or not. So from that point of view, I think we all will identify with this change. Okay, anytime I'm done, just go ahead and change global objectives. Let's see what the learning objectives are. Describing the common mental health concerns of people with MOUD, with OUD and who we're prescribing medication for. Review the epidemiology and management of co-occurring mental illnesses, and discuss the role of buprenorphine as a novel antidepressant. That's something that's really right now in the psychiatry wheelhouse, but we know that once something gets some traction and some evidence for it, that it'll come diffuse out into the other spheres where we care for people with mental health concerns. So let's see, common mental health concerns in persons with OUD. Consider protracted withdrawal. We'll talk about that a little bit. Post-acute withdrawal syndrome that we can see especially when people are starting on buprenorphine, that can mimic other mental health concerns. And then those primary psychiatric disorders that we see the most are depression, anxiety, sometimes with panic attacks, often overlying post-traumatic stress symptoms in our patients, and then personality disorders that kind of interweave. Other complicating factors, we'll talk about dual diagnosis, but as Chris points out, sometimes our patients actually have a triple or a quadruple diagnosis. They might have had a traumatic brain injury that might influence dosing effects and side effects, and they may have some limitations in terms of how much they're going to improve, especially if they have some irreversible cognitive damage. If you think of the lives of patients who have active substance use disorder, you see there's so much at risk for accidents and for violence that this represents a considerable group for us. Chronic pain conditions and chronic pain syndromes we allude to in many of our presentations, and then to think that chronic pain itself predisposes patients to have depression. There's that triple diagnosis thing at work. And the chronic medical conditions that we know are prevalent in this group would include hepatitis C, HIV, cancer, all of which can have some cognitive and psychiatric parts to them. So what about this protracted withdrawal? Symptoms can last from 2 weeks to 2 years after acute withdrawal from alcohol and other drugs, peaking at 3 to 6 months after cessation of that other drug. And common symptoms are mood swings, anxiety, irritability, tiredness, variable energy, low enthusiasm, problems with concentration, memory, coordination, and disturbed sleep. So you could see from that variety of symptoms that there's likely a kind of a physiologic part to this. And then you can see many of the symptoms might just refer to those life changes that patients are making in how they're spending their time, how they expect their mood to feel, their relationships. And so appears that 3 to 6 months is the time for us to think about that set of symptoms. Typical management is really behavioral, looking at diet, exercise, rest, relaxation, and self-care, and that adage from AA, one of those slogans says, give time, and for patients to have reassurance that they're going to feel better at some point. Substance use disorder increases the odds of a mood or anxiety disorder. And you can see for those ones that we encounter the most that, let's see, what are the kind of most pieces that jump out the most? Well, if we look at bipolar disorder and look at the prevalence of dependence on a drug such as an opioid, having bipolar disorder is a big predisposer. Dysthymia, depression, and panic disorder more than generalized anxiety. Seems like a person can have social phobia and not be at that much of an increased risk of having alcohol dependence or dependence on another drug, even though you think of those patients, you know, taking a stiff drink or relaxing with some marijuana before they have to go and mix with people. This is from a 12-month prevalence study, and it's not dated. It would be very interesting to see as the pandemic winds down if those numbers have remained the same or changed. Mood disorders work the other way too. They increase the prevalence of substance use disorder. So, you know, one is so much more likely to be accompanied by the other. So in patients with major depressive disorder, substance use disorder is increased, is more likely by a factor of 2 or more. And major depressive disorder is associated with worse substance use outcomes and with more psychiatric symptoms and an increased suicide risk. For those with bipolar disorder, as we saw, the substance use risk increases by a factor of 4 or more, and prognosis is worse for those patients with bipolar disorder and an accompanying substance use disorder. What about anxiety? Anxiety disorders also increase the prevalence of substance use disorder. Any anxiety in the past 12 months results in 15% of those people having at that 12-month mark a co-occurring substance use disorder. Generalized anxiety disorder, 50% had lifetime comorbid substance use disorder. Social anxiety disorder, we can see has less, but still a significant increase in especially alcohol use disorder. So our clinical pearl is treat both. We don't have to decide or give priority to either the mental health diagnosis or the substance use disorder. We can treat both at the same time. This was not always the advice about working with patients with co-occurring mental health and substance use disorders. For a long time, the idea was that if we treated the mental health condition, then the substance use would be a symptom and would go away. And then swinging the other way for a long time. And when I was a fellow, the idea was really, unless the substance use disorder were treated and dealt with, we couldn't make any headway with the mental health disorder. But we know now that that didn't work well either. So treating both disorders at the same time is the way to go. And we often see that some of our medication and our counseling behavioral approaches really are applicable and helpful for both diagnoses. So don't withhold psychiatric treatment just because the patient is using substances, even if they're not committed to stopping their use of those substances, and encourage honesty about the use of those substances so the patient doesn't feel that they're going to be rejected or forced to make a choice they don't want to make about those substances when they're not ready, and link the use of the substances to the treatment of the mental health disorder. Follow closely, monitor for effectiveness of medications and for decreases in substance use disorder that may occur over time, not as a sudden decision that a patient makes with 100% immediate success. So we have to give time too as the caregivers. Treat the disorders simultaneously, consider level of care, use motivational interviewing around the substance use disorder where we're having patients clarify their goals and how they would like their life to be. And definitely we know that medications specific for opioid use disorder are effective and result in more abstinence and less use. For the mood anxiety symptoms, we always really want to screen and see how much attention we need to pay. Certainly for patients with severe mood and anxiety symptoms who are at a higher risk of suicide, I in primary care am going to be referring that person to psychiatry and to really think about how serious and persistent those are. And I would always, want to have that backup. Antidepressants are more effective than placebo, especially in alcohol-dependent patients with depression. So if we think about that patient that tries to deal with their mood by taking some drinks, we know that if we intervene with a medication, we're going to be helpful there. Less evidence, says Chris, and should she come on, we might want to clarify that with her about effectiveness of antidepressants in cocaine and opioid dependent patients. And probably I would say amphetamine dependent patients as well. So we may want to revisit that point. Thinking about medication for depressive disorders, SSRIs are recommended as first-line treatment. Patients need to be primed so that they're going to have an adequate trial and not have unrealistic expectations that they'll immediately feel better, but we want to try to get them to stick with their medication for a minimum of 8 weeks to decide if it's been effective for them or not. I think when we reassure patients that it really is up to them, and that if at that point they find that that the medications are not effective or anywhere along the way, they have the option to stop using them, but we would want to coach them along the way, especially since an abrupt cessation of an SSRI can result in some symptoms that are confusing to patient. So if that adequate trial fails, we could move on to an SNRI. That would be venlafaxine, duloxetine, especially helpful for patients with chronic pain. Mirtazapine, helpful for patients who need to sleep at night and gain weight. And bupropion, which can be more activating, which some patients need, and also can be helpful for those patients that define as one of their goals in recovery, smoking cessation. How about medication for bipolar disorder? All of these medications have been around for some time and they're familiar to us. I like to have a psychiatrist on board if I have a patient who has lithium, but certainly in other primary care settings, the primary care provider would really be managing the bipolar disorder independently. So here is Chris is telling us lithium plus valproate, that would be Depakote, is superior to lithium and placebo among alcohol-dependent patients with bipolar disorder. So when you have that, what are we at? I think we're at 2 diagnoses there, bipolar disorder and alcohol use disorders. There's a situation where that extra medication is actually more helpful than going, one at a time and spending a long time on lithium alone and evaluating. We need to have caution in reproductive aged women because of potential side effects of both of those. So now there are trials that have studied a variety of these other medications in substance using bipolar patients, and there's some limited data on second generation psychotics. I see there is like a good conversation going on about co-sedatives and combined use of a variety of these medications with the psychiatric disorder, and I think at the end let's maybe Sarah, you could maybe summarize those questions when we get to the end. I'm just going to keep an eye on the time. So there it is. I guess, you you might update us about those second-generation antipsychotics. Anxiety disorders are so common, it's really hard wherever we're working to avoid having patients that have an active anxiety disorder, and can be challenging for us to treat whatever we're trying to do with them. Again, SSRIs are still first line, and the one I would tend to use would be escitalopram. Works quickly and works better on anxiety, but there's a variety, and I like to have some consultation. So sertraline and paroxetine are studied and indicated when anxiety is a result of PTSD. And then SNRIs also have effectiveness here for generalized anxiety disorder, panic disorder, and social anxiety disorder. Buspirone is a kind of standalone that's effective for generalized anxiety disorder, but not for panic disorder or social anxiety disorder. Although honestly, I've had patients with a prescription for buspirone who really use it in a kind of placebo way, that when they have a panic attack, they use some buspirone and they report feeling better. That's the kind of power of the placebo, because there's no evidence for that to happen. Medications for anxiety disorder. So here is a message from Chris in large font, underlined and bolded. Benzodiazepines should be avoided in current substance use disorder and used with extreme caution in patients with a substance use disorder history. So even though they have a role, and in the buprenorphine prescribing world, we have decided that we're going to be able to accommodate certain patients that have benzodiazepines. We still are treating them with a lot of caution because of that co-sedative problem. The combination of a benzodiazepine with other sedatives can result in respiratory depression and death. So considering other non-benzodiazepines, so hydroxyzine, diphenhydramine, those are sedating older first-generation antihistamines. Clonidine also provides some sedation, but not the same risk of respiratory depression. So I guess the message is really, whenever there's a benzodiazepine, we want to question why it's there, if it needs to be there, and who's the prescriber and why. And certainly when we're seeing a benzodiazepine on a drug screen and no prescription, we don't really know then what the patient is doing, what their pattern of use is, and how much risk they're at. So that's a kind of a reason to stop along the way and to really address those patients with those questions with the patient and make a treatment plan. Chronic pain considerations, we talk about this elsewhere, but just to point out that chronic pain may be increased with patients who have a more organic brain, fixed brain damage, and that medications might have to start at lower doses to be tolerable and increase more slowly, and that they may have unusual or idiosyncratic effects in traumatic brain injury patients. So to just want to identify that problem if it exists. That would be a kind of a place to use not only a psychiatry as a consultant, but also a neurosurgeon or neurologist who's familiar with those problems. Chronic pain, as we know, we're always going to be considering and encouraging our prescribers to use medications that may treat both pain and mood symptoms, such as the SNRI, duloxetine, and gabapentinoids that can be helpful for chronic pain, but also can be stimulating or rewarding for patients. And again, they're a group that we want to be careful about using, not use casually without monitoring. Here's just a little bit of a kind of message that I know Chris reads and updates periodically, and that is thinking about buprenorphine as a novel antidepressant. Because buprenorphine is a partial mu agonist and a kappa antagonist at higher doses, and kappa antagonism gives antidepressant effects, we might think that our higher doses have antidepressant effects, but in fact, the studies show something different, that a very low dose of buprenorphine can have some effectiveness on depression. So low dose buprenorphine improved treatment-resistant depression observationally, and just thinking about what the conditions would be to have to do, say, a big randomized controlled study, it might be hard to get the kind of numbers you'd need for a really valid study, but certainly this seems to be a common situation where there's co-occurring depressive symptoms and the person is using their SNRI or SSRI or bupropion and just not getting better in the way that you'd expect. So there are some randomized controlled trials of this combination of buprenorphine and samidorphan, and used as adjunctive treatment for depression. Novel and promising candidates. So, there's an example of recognizing the dual diagnosis that we often have, and looking at ways to improve our management of both parts of that, the mood part and the substance part. Here are some references, should you want them. I'll take a look at them. And I think I'll ask Chris just as a kind of follow-up if there's anything new in that literature.